Are you ready to elevate your expertise in the pediatric cardiology field? Welcome to the Pediatric Cardiology Fellowship, a premier one-year online program designed to equip you with advanced knowledge in the pediatric cardiology field. Our aim is to provide you with high-quality educational materials and up-to-date pediatric cardiology scientific knowledge delivered by a panel of highly qualified international expertise. Our professional panel ensures that the curriculum is high quality, up-to-date, evidence-based, and well-structured. Why travel for training when you can learn from top pediatric cardiology experts online? Our program brings world-class instruction directly to you, no matter where you're located, through case-based discussions, Q&A sessions, virtual workshops, and personalized feedback. You'll receive the same high-quality education as an in-person program, all from the comfort of your home or workplace. Our pediatric cardiology program offers a comprehensive fellowship structured into 3 modules, 16 weeks each, with a total of 96 credit hours and in-depth training over 1 year period. Balancing work, life, and professional development can be challenging. Our Pediatric Cardiology Fellowship is designed with your busy schedule in mind. With self-paced learning modules and live virtual sessions, you can advance your skills without disrupting your clinical duties. This program allows you to learn and gain experience at your own pace. From mastering congenital and acquired heart diseases to specialized training in ECG, echocardiography, cardiac imaging, including MRI, diagnostic heart cath, electrophysiology and arrhythmia management, mechanical circulatory support, and cardiac critical care. You will develop the essential skills to manage children with various kinds of heart disease at any circumstances and healthcare setting. Upon completion, you'll earn an internationally recognized AACME accredited graduation certificate, helping you enhance your credentials, advance your career, and improve your patient outcomes. Join a growing community of pediatric cardiology professionals who have transformed their careers through this fellowship. Don't miss this opportunity. Take the first step towards mastering the pediatric cardiology specialty and transforming the way you deliver care to your sick children. Limited seats available. Don't miss your chance and register today.
Hello, everyone, and welcome to our heart failure webinar. Today is a very special webinar to us, and we have the pleasure and honor to have Dr. Osama Dadah to organize this event. Dr. Osama is a consultant pediatric cardiologist in King Abdulaziz Medical City, Riyadh, Saudi Arabia. He is board certified. He started his career as a general pediatrician. Then he decided later, after doing his Saudi Board of Pediatrics, Arab Board of Pediatrics, and Jordanian Board of Pediatrics, to do training in pediatric cardiology. Then he is a certified pediatric cardiologist in Saudi Arabia, and also he did a certification from the European Association of Cardiovascular Imaging and Echocardiography. Dr. Osama is highly involved in education for medical students, for fellows, and for residents. And he is my best friend, and he is one of our key person and cornerstone person in our Pediatric Cardiology Fellowship. Without further ado, I will let Dr. Osama to introduce the webinar and the speakers.
Thank you very much, Prof. Amr, and welcome to everybody. I will not take long time, so I can leave the space for my colleague. Thank you for the introduction. As you saw in the promo, that we are going to launch a new idea, new experience, which is the Pediatric Cardiology Online Fellowship. It will be like 1 year. I will go fast through those are the board members and the people who will share in the lectures and the activities. As you hear in the promo, that you will have 48 weeks per year. Component are three modules, each module 16 weeks. So 16 weeks in module 1, 16 weeks in module 2, and 16 weeks in module 3. So it's like to cover the whole aspects of general pediatric cardiologist. I will show you the main focus. As you can read here, all activities and assignment will be monitored in the platform. You can enter anytime, morning, evening, afternoon, to see the lectures, to see the journal club, whatever. Nobody will argue about the importance of the e-learning nowadays because it make our life easy, and you know the power of the technology now. Nobody can ignore this issue. So I think this is one of the important step to improve your relationship with the e-learning and with the online lectures. So module 1, we will focus on the basic cardiac anatomy, embryology, physiology, pharmacology. We'll talk about general pediatric cardiology problems like myocarditis, cardiomyopathies, rheumatic heart disease, and we'll talk about many diagnostic tools. And those will be, as I mentioned, 16 weeks. The other module, we'll talk about the acyanotic congenital heart diseases and the cyanotic congenital heart diseases, and also the neonatal cardiology. Then in module 3, we'll focus on the perioperative and cardiac critical care mainly, and to cover the difficult topic in electrophysiology and heart failure and transplantation. This fellowship is accredited by the American Association of Continuing Medical Education. The team with the leadership of Prof. Amr, they are trying to get recognition from different institutes like the Saudi Council, the Egyptian Commission, and so on. Still, we are in the beginning. Hopefully, in the future, we will get this. It will give you 32 hours credit for the modules in each module, so it is total of 96. We have candidate already registered from different Arab and non-Arab countries all over the world, and still there is room for accepting more candidates. I hope I believe that the fees for this fellowship is nothing. You can go and attend conference with such fees or even more in Europe or USA. So this is like 1 year, 48 weeks with many lectures, journal clubs, MCQs. So you can also use the promo code for discount. I have a lot of things. If anyone interested to register, just communicate with me or with Prof. Amr, and we'll tell you the summary. Just last thing that I will tell you, that in each week of the 48 weeks, you will have one lecture with 10 MCQs. You will have journal club with 10 MCQs, and also you will have 10 case scenarios. At the end of the each block, you have to do the exam and submit your answers. This is in summary. I don't want to take a long time to give chance to my colleague, and I hope anyone have interest in pediatric cardiology, he might join cardiac center, or he's working in a general pediatric hospital with pediatric cardiology service. I think you will get maximum benefit from this fellowship, and thank you very much. Now we can go to start our activity today. Doctora, if you can share your lecture, Dr. Dimna. Now it's my pleasure to present the first lecture, which will be presented by my colleague and my senior, Dr. Dimna Kalila. Dr. Dimna is consultant pediatric cardiology, pediatric heart failure and transplant. She is the director of pediatric heart failure unit at King Faisal Specialist Hospital and Research Center in Riyadh. I hope you will enjoy the lecture. She will talk about updated medical management of heart failure. Welcome, Dr. Ademna, and the mic is yours.
Hi, hello everyone. First of all, I want to thank you for the invitation to the organizing committee. I'm very happy to speak about this amazing and important topic like is the management of pediatric heart failure. As you know, the update medical management in children is a little different than adults. In adults, we have different guidelines since a long time, and every 2-4 years there is some update of these guidelines. In children, there are less guidelines, although now start to be more and more publication, like it is recently from the ISHLT. But the first thing and the first ideas I would like to share with you is that the pediatric heart failure is different to the adult heart failure because the etiology is heterogeneous, are different trajectories because the journey is different. There are some changes conforming the age of the patients. There are limited trials, though we have to extrapolate it off our experience of the guidelines, but more important experience. And the medical therapy, like this is a long journey for our patients. We have to stabilize the patient and later on check when the patient is going to have not enough with medical management, and we need the timing for LVAD, transplant, or the decision of this patient, which is the best for the future of the patients. First of all, as you know, the etiology of heart failure is completely different or is more variability. We have heart failure including in fetus, that the major presentation is an EDROPS. In neonatal period, normally is more congenital heart diseases, that the manifestation after closure the PDA. And in children, adolescents, we have cardiomyopathies, myocarditis, arrhythmias, congenital heart disease with or without repairing, and other reasons like oncology after treatment or rheumatology. So you are using the same drugs than adults, but normally it's different targets because there is in some of our patients the myocardium is developing is differently the myocardium structure depending on the age. In infant neonates is differently, and it's not only heart failure in pediatrics. One more often disease we can have cardiomyopathies. It's different if we have dilated cardiomyopathy, restricted cardiomyopathy, hypertrophy, and sometimes we have during the timing mixed of this cardiomyopathy, starting with restriction and other during time DCM, dilated cardiomyopathy. And some of them we have congenital heart diseases. And in these cases, we can have RV systemic, and the management of the right ventricle is differently when it's in systemic position or the single ventricle physiology. So we are handling with immature calcium management in the smaller patients and this altered beta adrenergic response with higher heart rate dependency in the smaller babies. With in infants, we have limited preload reserve, and it's very important the ventricular vascular interaction. These patients, they have a lot of diseases that could provoke some changes in the pulmonary vascular disease, and disease could be earlier or sometimes appear long time after that. And the coupling of the ventricular arterial is important in this case, especially when we have a single ventricle and we have congenital heart disease. When any damage is going to provoke any event, etiology provokes a volume overload or pressure overload or ischemic or dysfunction in the contractility and distensibility. This is going to provoke a damage, ventricular dysfunction, and they start to try to compensate mechanism to try to compensate because the tissues needs some more flow, more oxygen, and this is provokes at the end heart failure. So now the physiology of the heart failure is based in the compensatory mechanism in the failing heart. At the beginning, the initial compensation of the heart is trying to hypertrophy, increase the force, but this is going to provoke changes in progression of the in the anatomy. It's going to provoke some hypertrophy, some ischemia, changes in the extracellular and intercellular signals, and changes in the remodulator of the ventricle. And these changes is going to provoke some inflammatory oxidative stress, and it's going to provoke more damage. The compensated mechanism at the beginning, we know that is try to increase the cardiac output. It try to increase the retention of sodium, the renin-angiotensin and sympathetic nervous system try to compensate because there is the tissues did not receive enough energy, and there is this at the beginning. This is changes provokes benefits in the with this transitory compensation, but as I said, later during time, there is deleterious effects for long term. So this is what is going to provoke all changes in the ventricular remodulating. It's going to provoke more heart failure, like alteration in the myocyte biology, alteration in the myosin heavy chains, changes in the adrenergic response, and hypertrophy with loss of myofilaments, and changes in the myocardial with necrosis, apoptosis, and degradation of the matrix and replacement with fibrosis. This is going to provoke mitral changes, mitral valve incompetency, and this is the circle, the vicious circle of the failing heart. All these changes is going to provoke more and more heart failure. For this reason, we have the treatment is based in this pathophysiology currently. On other hand, is try to control the neurohormonal mechanism that we said. This dysfunction provokes for the putting in march of the sympathetic nervous system activity. This going try. We have to focus on that. And by the other hand, what is happening is that the heart starts to fail, and they feel that cannot respond to the kidney, to the body. For this reason, start to become like an exocrine gland, start to increase, and this is the natriuretic peptide system. The heart start to try to release with the baroreceptors, start to release this peptide natriuretic, which has an effect in the vasodilator, systemic vasodilator effect. Why is important? Because one base of this treatment currently is based in the natriuretic peptides that you know we are using now, Entresto, that is 2 medications that later we can go to explain a little more, is because we have one enzymide in the membrane, the myocytes membrane, that is neprilysin. This is an inhibition of this neprilysin provokes that more peptide natriuretics is circulating, and the peptide natriuretics is going this to provoke this effect, can help us to know if the patient is in heart failure. By the other hand, you can inhibition, there are more peptide natriuretics in the blood circulating, and this provokes and help to the heart. So the summary currently of the pathophysiology of chronic heart failure in children is these pathways. By one side is the renin-angiotensin sympathetic nervous system, okay, that provokes the vasoconstriction and the neurohormonal, and the system of natriuretic peptide that we have to increase the peptide natriuretics, and this peptide natriuretics is clearanced by the neprilysin. Based on that, we are treating now currently. Allowed to this time in explaining a little about the pathophysiology to understand why we are giving this medication currently. It is important. So what has not changed currently is still we are using the neurohormonal blockage. This is the base of our treatment. And the diuretics is only for symptoms control. It's very important because normally all the pediatric intensives when patient is in heart failure, the first is to start diuretics, take care. This is not. This is part of the management when the patient has symptoms of overflow. And by the other side, we have to base the treatment based in which is the phenotype, which is the heart failure manifestation, okay? We have to optimize the patient, reassess dynamically, and integrate if the patient is responding or not to check where we are. For this reason, currently, the current model that we have is in neurohormonal but natriuretic peptides. This is the current model of the heart failure in general. For this reason, the neurohormonal treatment consists into inhibition of the aldosterone with the spironolactone, inhibition of the norepinephrine that provokes more vasoconstriction with the beta blockers, inhibits the ACE inhibitors or the angiotensin receptor blockers to inhibit inhibition of this progress of the heart failure. And we have to check, so this is for chronic patients in DCM. There are some cardiomyopathies. It's not the same for the restricted cardiomyopathy with the hypertrophic cardiomyopathy has a different specific treatment, and the response of this treatment is variable depending on the age and the. So if you have a patient with heart failure with DCM, you have two medical therapy and started with the treatment progressively depending on the symptoms. What we are using, the digoxin, digitalis, still we are using digoxin, although in the current guidelines looks like it's out of the main treatment. We can use it. It's very important, for example, in patients in the single after the second Norwood step. After the Glenn in the single ventricle, this could help to the single ventricle, but sometimes could have some effects in some other patient. The most important now, the new guidelines, is the introduction of the Entresto. This is the union of sacubitril or valsartan. We saw the valsartan is inhibitor of this area of the neurohormonal, the angiotensin 2 blockers, but the sacubitril has the effect inhibition of the neprilysin to increase the levels of peptide natriuretics. This is two medication in one. And this is in adults, they show that is in the paradigm trial, there was successful results. In children, still is not clear the use, although all the heart failure teams were using more and more because we've seen that these patients start to improve, but the panorama that was used was a study done in patients didn't show that benefit, no superiority comparing with Entresto. But our results mean in some cases, this patient, when you start, the patient is deteriorating, the patient is with ACE inhibitors, you stop the inhibitors, the ACE inhibitors, you have to wait 36 hours, and you start Entresto, and the patient start to be clearly that the biomarkers start to improve and clinically improve. So there is another medication that is used in adult, and in children maybe there are some effect, that is the ivabradine. The ivabradine is a selective inhibition of the CNS node for a current inside of the CNS node of the IF, and it provokes a reduction of the heart rate. There is no negative against the inotropic support, so it's good, and there is no reduction in blood pressure. This is some benefits in patients with persistent tachycardia after optimize the beta blocker treatment, or the patient is not tolerating well the beta blockers, and you can start this medication. Another medication that we are using more and more that has been very clear use in adults, that the adults is the CGLT2 inhibitors. This is an stabilizer of the membrane. Mainly the effect is in the kidney, started to use in diabetic patients, in adults, but they start to say that there is an stabilizing of the membrane and has a good effect and reduce the cardiovascular risk and death in adults. This is the name is empagliflozin and dapagliflozin. There was these trials. In children, there is no use globally worldwide, but we are seeing that there is clearly an effect you can use in congenital heart disease or heart failure. Not initially was used in patients with obesity, diabetes. Now we start to use more in congenital heart disease cases, and we can check how the patient is improving because there is a mix improve the functional class and is improved in the natriuretic reduction of the natriuretic peptides. What happened in the congenital heart diseases? The etiology is mixed in the etiology of heart failure, and there are different reasons, but the most different that we have to take care is that this patient could have mixed. We can have congenital heart diseases, and we can have alteration due to individual genomic variation and modification of their RNA, and this patient could have heart failure mixed with the congenital heart disease. And this is important for the follow-up of this patient. The patient with congenital heart disease, when it starts with heart failure, and normally it could be around 25% of these, all of our cases, start to deteriorating, and the prognosis is worse to long term. So this patient needs to be taken care because the probability of death during waiting for the transplant is higher. In these cases, we have to refer when we have an RV systemic. This is the right ventricle is positioned under the systemic valve until the aorta. Of course, this right ventricle is exposed to systemic afterload. This is, for example, after atrial switch operation, after TGA, or, for example, after this is patients affected for the congenital corrected transposition. And, of course, the response of the guidelines after that we saw previously is a little differently because anatomically the RV is differently. So it's the new guidelines, they saw that this patient could respond better, for example, to Entresto and the SGLT2 inhibitors, and you have to take care in these cases. There are multiple structural and physiology differences between the RV and LV, and the fibrosis, dilatation, arrhythmias, and multiple surgeries could affect more than in the left ventricle cases. Of course, in the Fontan, the physiology is differently, and this patient could have some manifestation of heart failure that is not clearly as we are measuring with the normal biventricular heart, and we have to take care that this patient is a failure of the circulation, and there is more of the end organ complications due to the stasis of the fluids, the hepatic congestion, cirrhosis, and another complication like protein loss in enteropathy or plastic bronchitis, and this is due to there is a circulatory failure more than a pump failure. We have to take care because the management of these cases is completely different. There are new therapies that is out of this meeting, but this is two of them new selective cardiac myosin activator, for example, omecamtiv mecarbil. This is used in adult that maybe in the future could give us a role in children, and we have vericiguat. That is it's a novel treatment in adult. They use the study that is called Victoria. Now we are studying in children. That is Valor. We are ongoing, and this is a novel soluble guanylate cyclase simulator. Okay, this is oral, and this could be advantage for the future. So we said about that their heart failure now models is about neurohormonal, natriuretic peptides, and maybe there could be some immunological either, because we know that during the aging there is an inflammation that provokes that the heart failure. So maybe the future we can to start to taking care of these patients since immunological part. What we know about the treatment? As I said, we have diuretics, digoxin, renin-angiotensin aldosterone, beta blockers. We have the inhibition of the aldosterone. We can add ivabradine, the CGLT inhibitors, and we have to take care of this patient conforming the ejection fraction is reducing. We have to add aspirin anticoagulation, and we have to intervene in a non-pharmacological treatment, like could be lifestyle, nutrition support. And this is important, that the most important is a summary. This conforming, we have to establish which is the situation of the patient, and the treatment that we are going to given has to be progressive depending of the biomarkers are guiding the therapy depending of the clinical status, and imagine the echo, the MRI can give us an idea how the situation is the patient. With the NT-proBNP, we can follow if the patient is controlled or not. With the RV function, the ventricular strain give us an idea if the patient is deteriorating. We can check with labs if the kidney, liver start to have some problems. And so we have to reassess this patient conforming clinical status is deteriorating. And we are following, as you know, the classification depending of the clinical status, the NIHA class functional in children, the Roche functional, and the intermass conforming the patient is not tolerating. This is more and more the patient conforming is refractory to the symptoms require a special intervention. This is all pediatric heart failure management protocol. All of us, every hospital has a heart failure management how has to be increasing the medication conforming the patient is deteriorating. We have to take care. If the patient has a restricted cardiomyopathy, the management is different. If the ejection fraction is maintained, is preserved, the response of the treatment is going to be differently. If the patient has a hypertrophy cardiomyopathy, we don't have to follow this protocol because we know that the management is completely different depending on the etiology. If it's rhasopathies, if there is any deposit, if there is anything. But or treatment for the dilated cardiomyopathy has to be established depending on the clinical status of the patient, and conforming the patient is deteriorating, we have to think which is the next step to do. And of course, this treatment has to be summarized and has to be joined with non-pharmacologic therapies. It's very important, the lifestyle, the nutritional support, the psychological support, all heart failure units needs to have a palliative care unit to work together because this patient conforming is deteriorating, what to think about transplant, LVAD, and this could be very stressful for the families, and we have to work on that previously to the patient deteriorated. So I know that is very big and a lot of information. I didn't explain all of the details. Maybe in the question we can talk about what to do with the treatment, most doses, what to increase less on. But this is a take-home message that I think that is important to remind, and that the physiological, the heart failure physiology, the reasons in pediatrics is more diverse. So the new drugs help, but it's more important to not replace the judgment. We have to follow this patient, that some of them, they have congenital heart diseases and they require more caution, what to check other aspects like pulmonary hypertension to be treated with that. And we have to integrate it, the biomarkers, the clinical status, the imaging with the therapy that we have to give. Because it's not only the medical therapy. There is a moment in there is no enough treatment. The medical reach the ceiling, and we have to think about which is the next step. And the red flags is failure to titrate, the patient not tolerate increasing of the medication because, for example, with Entresto sometimes increase, the blood pressure drops, and the patient feel symptoms that the heart failure is not going well, or the patient start to have persistent data of congestion with hepatomegaly, or data of pulmonary edema, or recurrent admissions that the patient require inotropic dependence, inotropic support. In this case, the mechanical support becomes the next step for transplant as the or next step either. Okay, thank you so much. I hope that later during the timing for question we have time to respond all. Thank you.
Thank you very much, Dr. Dimna, for this very excellent summary and comprehensive presentation. If you allow me, we'll go to the second lecture, then we can take the questions, so the picture will be completed. Now we'll go to the second lecture. If Doctora, you can share your lecture. It's my pleasure to present my colleague, Dr. Aman Silmi. Dr. Amal is a consultant pediatric cardiology, pediatric heart failure and transplant. She's the team leader of the heart transplant, pediatric heart transplant at King Abdulaziz Medical City Ministry of National Guard, Riyadh. Dr. Amal is going to talk to us about the mechanical circulatory support, some overview, which will help us to complete the picture of management of heart failure. Welcome, Dr. Amal, and the mic is yours.
Most welcome. Good evening again. So today I will be going to talk about mechanical circulatory support in children. Today about classification of heart failure, indication of mechanical circulatory support in children, intent of VAD implantation, patient selection and pre-implantation evaluation, the types of devices and criteria for selection of each type, the post-operative management and optimization, anticoagulation options, adverse events, and overall outcome. So again, Dr. Ademna spoke in details, but the stages of heart failure are four. First is the stage A, which is people who are at risk of heart failure or not in heart failure with normal echo, such as congenital heart disease, normal function, and dystrophinopathies. Stage B heart failure, which is the pre-heart failure, where the ejection fraction is low, but the patient is asymptomatic, so phenotype positive. And those patients are indicated to go on heart failure treatment. Stage C heart failure, which is symptomatic heart failure, which are started on guideline-directed medical therapy. The stage D heart failure, where those are the patients with the marked heart failure symptoms that can interfere with the quality of life and require recurrent hospitalization. Those patients needs to be on optimized medical therapy, and the progression from stage C to stage D heart failure is usually very insidious. And at stage D, you have to consider the mechanical circulatory support. And when you talk about stage D, you have to decide the Intermac profile. Intermac's profile is stage 1, which is the cardiogenic shock called crash and burn. Intermac's 2 is declining on inotropes who are sliding fast. For Intermac's 1 or 2, if you don't implant a device, then the result will be death. For Intermac's 3 is the patients who are stable on inotropes, but they are not weanable. And then from 4 to 7, those are the patients with the stage D heart failure, but they are at home with different symptomatology, and they are in medical management, but not well controlled. So the timing of the implantation is very important. Based on the PDMAC profile, PDMAC report, which was published in 2019, they have this Kaplan-Meier survival for those patients who had VAD. Those patients which had VAD on cardiogenic shock status, half of them were dead by the 12 months of support, while those patients, totally different from Intermac 3 and 4, where the 70 to 80% are alive after 1 year of support. So the timing, again, is the most important. That should be before significant end organ dysfunction. And still you are faced with those patients who are coming in cardiogenic shock. And those patients have the worst outcome. Therefore, those patients has to be bridged with a temporary measures such as ECMO or temporary VAD to stabilize before considering a durable implant to make sure that the patient can go on or not, and to clarify the diagnosis, to make the final decision. And there is evidence that end organ dysfunction, those patients who has this much of end organ dysfunction, they improve significantly with paracorporeal continuous flow device. And we'll talk about this in details. And so far, there is no clear explanation why those patients who are temporarily bridged are doing better than those patients who go directly to VAD. So again, the clinical indications: failure of GDMT, guideline-directed medical therapy with stage D heart failure. Post-cardiotomy failure is out of the scope of this unless those patients are post-transplant. They will require some type of mechanical circulatory support, and kids with arrhythmia that can lead to cardiogenic shock. It depends on the pathology of the arrhythmia, then the durable or temporary device will be decided. The intent of VAD therapy in almost half of the patients is a bridge for transplant, even more. And sometimes it's a bridge to candidacy in 34% of the cases, or to recovery, which is in a very low proportion of the patients. around 5 to 6%, and those are in the patient, depends on the pathology and etiology. And in very rare, it's considered for destination therapy, such as the muscular dystrophies, where the heart failure is the cause of poor quality of life. So it's just a palliative treatment. So the selection is very difficult, and the evaluation is not easy, and it should be measured between the risks and benefits. So the first thing is to assess the end organ function, renal, hepatic, nutritional status, respiratory status. Try to optimize, to go to the VAD in the best shape if you can wait. But sometimes the patients are very sick. You have also, as a VAD center, to document the threshold that you use. And this should be based on your previous data. And also you can be guided by the PDMAC reports, where they really change the threshold many times. However, the main thresholds are made for the renal dysfunction, the GFR, and for the serum bilirubin for congestive hepatopathy. It showed that those patients with a bad congestive hepatopathy and kidney dysfunction has the worst outcome, especially in the infants. The things to be also evaluated is the RV function, which is always, most of the cases, they will be non-invasive because they will be too sick to go for invasive measures. So by echo, you can assess by TAPSE, RV fraction area change, and clinical by CVP bedside. And if the patient is stable enough to go for cath, then it's good to assess the pulmonary vascular resistance, to assess the transplantability of the patient. And the most important part is to assess the social status of the patient and the psychology status of the patient on the family. So you have to assess the adherence to treatment of the family, the barrier to medical management, the expectation, and the knowledge that they have to know before going to this journey. The most important part is to assess the cognitive and neurodevelopmental functioning, which sometimes is prohibitive to going to VAD implantation. And then also mental health, substance abuse, social support, family function. This makes a really big part of the decision. And finally, the device fit. What device you will use, what is the weight of the patient and size of the patient, which is the major things to decide. So the workflow of the decision, first of all, you have to act fast. You don't wait. If you have patient with Intermax 1 or 2, you have to decide immediately. Does your patient need a mechanical circulatory support? So don't delay the decision. What is the level of support? Do you want to assist to support the left ventricle, the right ventricle, the both ventricles, or is it a systemic ventricle that needs support? And based on the size, you have to go on. And what is the intent? Are you planning to go durable and you're listing those patients for transplant right now? Or you need some time to work and to complete your workup. In this case, you need to decide about the temporary measure, temporary support device. And you have to decide if you need an ECMO before the decision. And any special surgical consideration given the weight of the patient and the situation or the anatomy of the patient. The types of the device are classified by either the duration, which there are some devices, I will talk about it in details, temporary and durable, and the flow pattern, which is pulsatile or continuous flow. The site of implantation, the paracorporeal and extracorporeal devices are outside the body. However, paracorporeal are near to the body, but extracorporeal are away from the body, but they are both of them, the pump is outside. The intracorporeal, where the pump is inside the heart, usually it's the left ventricle. And the intravascular, such as the Impella, we'll talk about it also. And what kind of circulatory support you will require? Is it LVAD only? If you need BiVAD, is it a systemic ventricle, or is it a total artificial heart? I'll just talk briefly about the ECMO. Usually the ECMO is the extracorporeal membrane oxygenation. There is VV and VA ECMO. So for the heart failure, you require VA ECMO, and it can be applied for all the ages and sizes. It is a short-term support, and it is contraindicated in severe irreversible brain damage or end organ dysfunction, which is irreversible, coagulopathy, and sometimes the access is prohibitive. The types are peripheral and central. The peripheral, usually you get the venous cannula, which is usually in the right IJ. and the right carotid, and the femoral axis is usually in the femoral vein. The central are better for many reasons. You can achieve better flow. However, it's an open sternotomy, and also you can manage to put an LA venting if required, because those patients in ECMO, the right heart is totally unloaded. However, the left ventricle is not, and the left atrium. With that, they will get high LA pressure and high pulmonary edema, which will affect the cardiac output, and it will damage also the lungs. So there are many ways to decompress the left atrium, by either percutaneously or surgically. Surgically is the best way if we go central by LA vent, or you can go percutaneously through septostomy. Sometimes you keep a device to keep it open, and you go insertion. Sometimes you're required to go for Ampella. The Ampella is a pump placed in the ascending aorta, either surgically or percutaneously, and it helps to decompress the left ventricle, usually for the older kids. The parts of the ECMO, I will not go in details. It's a pump and the oxygenator. The pump of the ECMO was continuous. It is a continuous flow, and it is either roller or centrifugal pump. Now current pumps mostly are centrifugal, which are much better than roller. The oxygenators is required in cases of lung damage or high or low saturation, and the heat modulator or exchanger. The cannulation and the flow are all based on the underlying diagnosis and the size of the patient. And there is a very good thing that you can apply an oxygenator, and you can even do the renal replacement therapy. So this is the best thing to go if the patient is in cardiogenic shock, to establish end organ perfusion, and then go and decide. I'm guided here with ISHLT consensus statement, which was published in 2021 about the devices. This is the brief about the devices. I will just talk about the most commonly used devices. We'll talk about PDMAG and CentriMag. Both of them are paracorporeal continuous flow devices. The PDMAG is for the little kids, and they can achieve flow up to 1.5 liters per minute, while the CentriMag can achieve high flow up to 10 liters. Both of them are for left ventricular support, and they can last up to 1 month, although really there are some cases which lasted for longer. The Ampella device is very now popular, and really it is promising for the kids. It's with different sizes, 1.5 to 5 and 5.5. They are mainly for the LV support. It's placed in the ascending aorta, as I mentioned. And they can last for up to 2 weeks, but I went through many cases where they really lasted for longer, until transplant. And this is with the thanks of the new anticoagulation methods, such as bivalirudin. There is an Ampella to the right ventricular support, which is really rarely required, mainly for the transplant patient who has post-transplant right ventricular failure as a temporary support. When we talk about the durable devices, the most commonly used durable device in pediatrics in North America, unlike most of the world, is the HeartMate 3. The HeartMate 3 is the intracorporeal, so the device, I will show you the picture. It's inside the heart, and it is a continuous flow. It is a magnetically levitated device, and it can give a very high flow, up to 10 liters per minute. It is usually for kids, it's a bridge for transplant, but for adults, it can be a destination therapy. The HeartWare, unfortunately, it's the same idea of the HeartMate. Unfortunately, it was stopped from the market recently in 2022 due to safety issues. And it left those patients with really like a gap in treatment, but now it's mostly replaced with the HeartMate. I think the profile of the HeartWare was smaller, so it was more fitting for the small kids. It's out of use now. Then it comes the Berlin Heart XCOR. The Berlin Heart is a beautiful machine. It is a pulsatile paracorporeal. It has many pump sizes. So the pump is outside the heart, and the pump size decides the cardiac output plus the rate of the pump. So you can provide from 0.6 to 8 liters, depends on the pump that you use, and it's well documented for the size of the patient. and it is a bridge always to transplant. Unfortunately, the downside for it is the high stroke rate, and the other thing is that the patient is not dischargeable. While in the HeartMate, you can discharge the patient home. The good thing about Berlin Heart, it can be used for the left support, the right support, and even for the systemic ventricle support. Jarvik is a nice device, very tiny, can be used for infants, but it's still under clinical trial. It is not approved yet for use. I will show you the picture. The total artificial heart is very limited use, and we use it for kids only for those patients with rejection post-transplant, also the cases of Fontan patients, but I really didn't see much of use for the total artificial heart with many complications. Just a picture for the Berlin Heart. Can you see it all? Can you see that? So this is the lift device, lift support. The pump is outside. The outflow of cannula is coming from the left ventricle apex and the inflow to the aorta. On the RVAD support, it is coming from the right atrium. So the outflow is from the right atrium to the pulmonary arteries. They have different cannulas, and their cannulas are very durable and stable. There is the Berlin Heart venous cannula. It's also under ongoing trial. It is for the support of the Fontan pathway, and it is very promising for those patients who are struggling with lymphatic dysfunction and high Fontan pressures. Just to show you, this is a very commonly used, the SentryMag or the PDMag. It is placed in the same places for the Berlin Heart, but the cannulas are not well durable. They are lower profile, and they are not durable. It's connected to a centrifugal pump, which is PDMag for the kids who are less than 10 kilos, and SentryMag for the older kids. Usually, it is temporary for another durable device. So the recommendation is to use the more durable Berlin cannulas and attach it to this pump. So if you have to go for a durable device, then you don't need to go again for a sternotomy. The continuous flow device is the HeartMate 3, HeartMate 2. It was replaced by HeartMate 3. The recommendation for the use is body surface area of 1.3. There is some reported cases to 1.2, even less. The pump is inside the heart apical LV apex, and the battery is outside. There is a drive line here. It protrudes through the patient's skin, and as I mentioned, they can go home with it. This is the Jarvik, just to show you how small is it, and it is really promising for the infants until they reach to transplant. Some surgical consideration you have to take care. The cannulation site, usually the standard kids, for many reasons. We can talk about it in details later, but there is no time now. But sometimes you have to alternate your position, and also sometimes you have to use a graft to facilitate the future transplant and to avoid impingement on any of the vital structures. The intracardiac shunt should be used closed because it can affect the flow, and it can also decrease the saturation. The aortic valve regurg, sometimes it's a contraindication. So in cases of severe aortic regurg, you have to make your decision about closing the aortic valve or repairing that. Sometimes the AV valve lesions, significant AV valve regurgitation or stenosis, can require repair, replacement, and even removal. And the exit sites sometimes has to be modified based on the patient's size. Post-operatively, you have to aim for a good systemic perfusion, appropriate device filling and emptying. You have to decide your cardiac index, so the cardiac output. And for the single ventricle, you have to set a higher single ventricle, higher cardiac output. We usually are guided by the echo and the hemodynamics, the CVP and the blood pressure. And you have to consider the anticoagulation. There are special considerations for pediatric patients for anticoagulation. The direct thrombin inhibitor has been a game changer for the patients on Berlin Heart. First of all, you have to achieve the hemostasis before starting anticoagulation, because this will affect the effect on the anticoagulation. Try to use the bivalirudin, which is now recommended by the by most of the companies. I'm talking now about Berlin Heart because the concern is about stroke for those patients. So bivalirudin is recommended, as well as antiplatelet therapy for the pulsatile flow devices. And you have to make your own protocol based on the availability of the medication and your experience also. The adverse events mainly are infection, bleeding, pump thrombosis. Pump thrombosis is more common in patients with HeartMate, while the neurological event and stroke is more common with those patients on pulsatile Berlin Heart. And it's all related to the patient. And there is a new nice paper from PDMAX about the adverse events definition and the grades of each adverse event. I really encourage everyone to go through it. The infection account for a significant proportion of adverse events, and the treatment, unfortunately, sometimes the only treatment is to go for transplant. Dry blood infections are really hard to treat, and the thrombosis of the device, it can happen mainly with the HeartMate. Therefore, you have to monitor those patients for the LDH and hemolysis. The stroke rate, as I mentioned, it was a big concern for those patients on Berlin Heart. But with many standardization of protocols and establishing bivalirudin and also controlling the BP, it reduced from 30% down to 17%. Bleeding is always an issue, and RV failure is something that you have to think about and be ready for it. So RV failure, you have the usual practice is to go for LVAD and to manage the RV failure post-VAD implantation. However, sometimes it's very clear that this patient RV is failing even before, so you shouldn't really take the risk and you should implant by VAD right away. Discharge, unfortunately, is only for those patients on the HeartMate. Even those kids on HeartMate, 30% only they are able to go home, unfortunately, due to many reasons. After that, if the patient is stable enough, you have to train the caregiver, you have to make a multidisciplinary outpatient plan for that, and this is not an option for the Berlin patients, although it has been done in Europe, few patients, but I don't think they all went through nicely. Just brief about the outcome. There are many registries for those patients on VAD in North America, and this is very important to look back. And this PDMAC has been really doing a great effort because they report their outcomes, they share the experience, and they go back, they change their practice from time to time to decide what is the best for those patients. And there is also the Action Network, another registry for the VAD patients. So based on the latest PDMAX report, which is the 8th report published last year, most of those patients who required VAD were cardiomyopathy, and then next was congenital heart disease, followed by myocarditis. After 6 months of VAD implantation, the favorable outcome was reached in almost 84% of those patients, and most of them were HeartMate with intercorporeal VADs, and the least are the continuous VADs, the paracorporeal continuous VADs, which is only 71%. The single ventricle and the congenital heart disease had similar outcome, and both of them were really inferior to those patients with cardiomyopathy. And Action VAD Registry, they published a nice paper last year, and it showed that the enrollment of those patients in the registry, this is not only a registry, it's a registry and plus a quality improvement and sharing a single protocol. They started with 100 patients, and now it's 256 patients. It has more than 100 centers in North America, and they enrolled some centers in Australia and Europe. The survival in 1 year was about 80%, and the stroke rate in those patients with the Berlin Heart was 13.7, which is much better than when they started. The infants were the worst, and the 1 year survival was lower with a higher stroke rate. So in summary, the mechanical circulatory support has changed the trajectory of heart failure management. It helped the children with heart failure to reach to their favorable outcome safely. The support requires collaboration, continuous quality improvement projects, and further research. The key point for success is the early and timely intervention and careful planning before intervention. I really advise everyone to go to the website for the Advanced Cardiac Therapy to Improve Outcome Network. They have a very rich website for the educational material for the families, for the caregivers, for the healthcare providers, and they have all the protocols that you need. You will find it on their website. This is the consensus statement that I used as a reference for my talk, and I advise everyone to go through the ActionVAD registry outcome as well as the PDMAC registry. Thank you, everyone.
Thank you so much, Dr. Amal, for this excellent presentation. I know it would be a little bit difficult for many of the audience, but I think it's a good chance to hear about the mechanical circulatory support. Now you know that patient with fulminant heart failure, not responding to medication, planned for transplant, decompensated, they need to go for this. There is LVAD, RVAD, and BiVAD.
It's my pleasure and honor to introduce to you Dr. Mohammed Vitil, who is a consultant pediatric cardiologist in Queen Elizabeth Hospital, London, and he is going to give us very nice case-based discussion with two cases of complicated children with advanced heart failure.
Hello, everyone. So I take this opportunity to thank Dr. Amr Al-Husseini for making me a part of this pediatric cardiology webinar. So today, so I've been asked to do a case-based discussion of basically fulminant pediatric cardiac failure. So these are some of the cases which I was a part of in managing while I was in Freeman Hospital. So we will be exploring advanced mechanical circulatory support, both extracorporeal and paracorporeal, and we'll have a brief insight into how we transplanted these kids. So first is a kid with viral myocarditis, a previously fit lad, 4-year-old, presenting with 4-day history of viral prodrome, with quite significant lethargy to an extent that he needed to be wheeled in, and he couldn't keep his head head raised off the bed, and reduced appetite. And slowly he was slipping into acute decompensation and slowly slipping towards cardiogenic shock. So he arrived in ED, tachycardic, hypotensive, still self-ventilating in room air, but increased work of breathing, reduced air entry bi-basally, gallop rhythm, pansystolic murmur, and liver edge of around 4 centimeters below right costal margin, with signs of end-organ hypoperfusion, lactate of 5.1, mixed venous stats of around 50s, elevated troponin, more than 35 grand, NT-proBNP, more than 45,000, vital PCR positive for parvo B19 virus. The kid, this is the X-ray, as you can see, cardiomegaly. So many times what happens is when the heart keeps dilating, especially the LV DCMs, the LV apex keeps pushing towards the LV left side. So there's many times when they arrive in our ICU, they have severe left lobe collapse. Could be basically LA so distended that it is impinging on the left main bronchus and thereby collapsing the airway in the left. And a bit of a long-standing DCMs, many times you can see hyperinflation of the chest as well. It's just, due to the severe MR and pulmonary venous congestion, the lungs are trying to compensate by creating an autopeep. Yeah. This child then went on to develop severe respiratory distress, needed positive pressure ventilation, CPAP, reduced urine output, ending up on triple inotropes. And as you can see, the echo severely dilated LV, reduced radial and longitudinal systolic function, EF15 Simpson biplane, longitudinal perisuggestive radial, longitudinal MAPC of 8 centimeters, diastolic EA-MV ratio 0.8, deceleration time of 250 milliseconds, global longitudinal strain -13, with spontaneous autocontrast in the LV, severe eccentric jet in the mitral, causing severe mitral regurg to an extent that it is basically causing diastolic flow reversal in the pulmonary veins, but no interatrial communication. The child on the same day got intubed, ventilated, just crashing. So despite all the medical management, progressive deterioration, lactate of 8.2, worsening acidosis, you're not able to see it actually. So mixed venous stats of 40, cerebral stats of around 42. So arterial venous CO2 difference of around 8 to 10. So the child is just not at all getting better. So I ended up on ECMO. So just before ECMO, LA, as you can see, LV massively distended due to the mitral annular apparatus getting dilated, mitral annular annulus getting dilated. Many times the posterior mitral leaflet gets tethered, so eccentric jet, to an extent that it is basically tracing back into the pulmonary veins. There's no intraradial communication, and there is massive spontaneous contrast building up. So child needs to be put on VA ECMO, peripheral VA ECMO into the neck vessels. So those of you who are not so aware of what ECMO are, so basically there's cannulas that stick inside IV RA junction, blood siphoned out, goes into a magnetically levitated centrifugal pump, which is an impeller pump, pushes blood into the oxygenator. Basically what the LV squeezes, the pump squeezes, sends blood into the oxygenator. This does the heart job, this does the lungs job, and that basically oxygenates and comes back into the heart through the carotid into the aorta, and is actually supposed to stay in between the first and second branch junction. So it stays there and then systemically perfuses. So basically bypasses the ventricles. So heart fails, you put on ECMO. Lung fails, you put on VV ECMO. These are some of our ECMO machines we use in Freeman. This is Electronic Centrimag, and we've moved on to the Quantum Medical Spectrum Charlotte perfusion system. A bit more techy, advanced machine, but it's pretty much the same, does the same job. This is the magnetically levitated centrifugal pump. Here it's a bit of the same centrifugal pump, but with vortex kind of a flow. More digitally pretty cool, a lot of touchscreen, and this is still buttons. Both does the same kind of a job. So we put the kid on ECMO, and the child ends up like this. So the condition just worsened. So this is a very common phenomenon. I'll tell you why this has happened. So this is the venous cannula. Many people think this is where the cannula ends. No, actually the cannula ends here. There's a translucent part and an opaque part. Blood siphoned out, pump oxygenated, and then comes back in the aortic cannula. So these positions are pretty okay, but this lungs were not this bad. The lungs are super bad here. So I'll tell you why this has happened. So basically, RA blood is siphoned out. So the RV has no blood, and the blood comes out in the aorta, and it goes out into the systemic circulation. So basically there's no pumping of RV, and there's nothing going into the MPA and into the lungs, right? But how come this? So if there's no venous congestion, how does the venous congestion happen? So what basically happens is the heart is actually just not contracting any at all. So it's just stiff. So there's impaired aortic opening. The aortic valve doesn't open. There's no pulse pressure in the if you do an invasive arterial line, and there's absent EDCO2, so reflecting no RV output. But still, the lungs are so super congested, as you saw in the previous slide. It's basically the bronchial arteries. So from the aorta, the right bronchial artery and left bronchial artery, they perfuse the lungs, and venous return from the bronchial veins drain into the pulmonary veins, and the blood comes back into the LA. Now all of this blood slowly accumulates in the LV, and there is an aortic valve is not opening. So LV just keeps distending, and there's increasing LV-EDP, and there is increasing LAP, left atrial pressure. All the blood then backtracks into the pulmonary veins, and or there's sort of auto contrast. Blood is just swirling inside the LV, and at risk of intracardiac thrombus, and the pulmonary congestion just keeps getting worse. So basically putting on ECMO. We're trying to rescue the kid by putting on ECMO, but ECMO is actually killing the heart. Increased LV-EDP, you have to remember, it causes reduced, it jeopardizes coronary perfusion, and that causes the LV to get even more ischemic. It's dilated, thinned out, and it's like wall stress is so much, the heart is just about to fail and die. So we do something called LV venting. It's a strategy. Basically, here in Freeman, they do an atrial flow regulator. This is a device. You perforate the intraradial septum, and then you stick this device in. You can regulate the flow through the orifice. That's why it's called an AFR, atrial flow regulator. So that so pushed into the cath lab. This was put inside, and we decompress the LA and LV, thereby reducing the pulmonary venous congestion and optimizing the myocardial recovery. So as you can see, this is post AFR. This is the atrial flow regulator which has been put inside, and then the lungs are happy, heart is happy, and now we basically save the kid. Yeah. So this is the device. I just wanted to show you how it looks like. As you control the orifice diameter, you can control the flow. And this is how it might look like on echo. So the kid, a few days on ECMO, we did try to wean off ECMO with levosimendan and infusion, but to not much avail, persistent ventricular dysfunction. So the child needed more durable support. So on day 7, we put the LVAD cannulas, but in Freeman, what we usually do is we put the LVAD cannula. So LVAD cannula 1 sticks into the LV, that is the inflow cannula, and then this is the pneumatically driven pump that then pumps, and then outflow cannula sticks into the aorta. So we put the LVAD cannulas, but we use the electronic center mag like a short-term VAD on ECMO pump. So these cannulas then go into the circuit, ECMO circuit, with heparin infusion on. By the time we procured the Berlin Heart X-Core ICUS stationary driving unit, once that comes in from Berlin, we then change the LVAD cannulas into the Berlin Heart pneumatic driven pump, and then we start bivalve uterine infusion. So some of the diagnostics we did by the time is basically endomyocardial biopsy, which is the gold standard to rule out myocarditis. So the catheter goes into RA, RV, and then takes a pinch from multiple sites, mostly from the interventricular septum. So just to understand, in DCM, already the walls are thinned out. So many times you can actually transmurally puncture the heart. So this itself can actually kill the child. But you have to be really careful. A lot of the interventionists need to be really skilled, and then you do it. And day 10, this was done. They were found in the immunohistochemistry, power B19, and myocyte necrosis. So it was confirmed. Cardiac MRI was done. There's something called inversion recovery images. 7 minutes after post-gadolinium, you find post-contrast enhancements that was found in the LV infralateral wall. So it was even more in the T2-weighted images. So that was actually more suggestive of myocarditis. We started IVIG, 2 grams per kilogram over 48 hours. A lot of that was given, and then even thought of corticosteroids, but it was deferred because of the viral etiology due to the viremia. Still active, we didn't want to worsen the viremia, so we deferred corticosteroids. This is a kid, 3 to 4 weeks later, extubated, rehabilitated, and the child was stepped down into our HDU. We call our HDU, we nicknamed it as Vadsville, because that's where all the children who live on Berlin Heart, they have school teachers come in and they live in our HDU, basically waiting for a heart. So he was in our HDU waiting for a heart and bivalve infusion, aspirin, clopidogrel. So what basically the VAD does is, the ECMO is a continuous flow, so VAD is a pulsatile flow. It reduces the RAS, the renin-angiotensin activation system, and thereby reduces ventricular fibrosis and vascular dysfunction, thereby giving time for the heart to recover. Some myocarditis recover, and you can explant them from the Berlin Heart. They can go home. But so we also give anti-heart failure medicines, beta blockers, ACE inhibitors, diuretics, and Entresto. And 2 to 3 months later, we did try to reduce the LVAD flow, increase bivalve, and we did serial functional echoes, but this child never recovered. So he was just waiting for a heart. So these are the devices which are used to carry the heart. So this is a Paragonic Sherpa Pack cardiac transport system. This is a cold storage, cold static storage. This is cold perfusion storage. Here, the heart is still beating, normothermic perfusion storage. This is like an ice box, but it's like a canister where the heart is suspended. There is a fluid inside, and the aorta is anchored onto the lid of the canister. Heart does not touch the bottom, and so basically this device has an app where the donors can chat with the recipients, a donor hospital chatting with the recipient hospital. And this is what we use in Freeman. So this is also being used in Freeman, but the problem is this can be only used for 50 kilograms and above, so adolescents. Here, the heart is actually moving. This is actually a moving image. For some reason, it's not moving. So heart moves. So the heart never stops beating in this device. It's called TransMedics Organ Care System for heart. There's for lung, there's for kidneys as well, liver as well. So here the heart keeps beating. It's normothermic, perfused. So how is it different? This is the thing which we use for infants and toddlers, for preschool children and smaller hearts less than 50 kilograms. Ex vivo HAT, heart assist transport, or heart box. They use HOPE, hypothermic oxygenated perfusion. So here I'll tell you, it looked like exactly like a photocopier. So I'll tell you more about it. As you can see, yeah. So the heart moves, yeah. Okay, there they basically suspended animation. So the aorta, there's a cannula that sticks inside, and it is maintained in a teardrop way where the aortic valve is kept closed, so they can perfuse. There's a blood and in a solution that is mixed, and then that perfuses the coronaries at low pressure. And it's put into an ice solution. So hypothermic, 8 degrees 8 and less degrees Celsius, and it's still perfused. So there is some oxygenation happening. Yeah. So this is what was used in Freeman. So as you can see, there's a cannula, bilumen cannula, that basically infuses this solution, this juice, which ex vivo cells, that basically is a hot solution, insulin, heparin, imipenem, potassium. It's a cocktail of many things. 2.5 liters, 2 liters of this, and 0.5 to 300 ml of blood is mixed, and then it's infused into the heart. It's zip tied, not sutured. And then once you take out the cannula, the surgeons just cut, so it's easy for them. So they just zip tie it, and this is an LV vent. It's put inside this, and the perfusion, coronary perfusion pressure is around 20 millimeter mercury. So they put inside this. So there's an LV vent. So it is, heart is perfused, the coronary is perfused the heart. Whatever leftover blood is just vented out through the LV vent from the left side, and from the right side they actually slit open the RA, and it actually sludges out whatever is left. Yeah, and this is what we saw earlier, the entire system. It's disposable reservoir. So TransMedics OCS, Freeman does use this but the technology is not for anyone below 50 kilograms, but anyone beyond 50 kilograms, adolescents, young adults, this is pretty awesome. Heart keeps beating inside, and the advantage is that this significantly reduces reperfusion injury risk, and it's pretty cool. This is one of the articles written by the cardiac surgeon Louise Amelia Kenny and Mohammed Nasser. These are the kick-ass surgeons in Freeman, and there's other cardiologists, David Crossland and Emma Simpson, who's an intensivist. She expertises in VAD. So there's an article for those who are really interested in DCD, DBD, and latest technologies used to transport heart. Thank you so much.
Just I will take two questions. There is actually many questions about the heart failure, the previous lecture, and also this one. But anyway, I will take one or two for Dr. Dimna, then one question for Dr. Amal, and then we will conclude. Dr. Dimna, you are with us, correct?
Yes, and I'm just trying to respond a lot of questions by that there are in there.
Actually, there are some questions already answered by you, like the question about Entresto, when to start, if the AC inhibitor no response, or when there is complication. I think you answered this, but you can clarify more if you would like.
Yeah. So the Entresto for me is a good medication. It's a new drug. Is good. The study, the trial done to check the which is the effect, that is the panorama, didn't show that there was too much effect. This is the first thing that for this reason is not used in some cases. We have to consider that Entresto is expensive, more expensive when you compare with the captopril initially. So when you saw the patient independent, the patient is small, is an infant. For me, I start captopril because captopril is short action. You can monitor him better. It's 3 times. Entresto normally is in some cases has huge effect, so it's more potent vasodilator. As some patients, they cannot tolerate it. So in general, I start ACE inhibitors, captopril, enalapril, lisinopril if there is kidney dysfunction. If the patient has side effect like coughing or angioedema, something, move to losartans or ARB blockers, okay? But if the patient is not improving, is deteriorating, in this case, move to Entresto. The Entresto I never start in less than 1 year, it's more, and in the small baby I prefer to do it with monitoring the blood pressure. Sometimes if the patient has borderline, I admit the patient for 24 hours, 1 or 2 days to check the blood pressure that the patient is. In some centers in US, maybe directly start with Entresto. This is true because it's potent. For me, I prefer to do it this way. Okay.
Okay. The last question for the heart failure. What about the aspirin or anticoagulation when you would start it in a patient with heart failure or dilated cardiomyopathy?
Normally, here, depending in the area, when I'm now in the Arabic population, I detect that there are more tendency to appear clots, a thrombosis. There are I think that is depend of the profile, maybe the genomics, and for this reason, okay, I think that for this reason, patients start to LV ejection fraction less than 30-35, I start with aspirin. And once I detect that the patient has thrombus, clots in the LV, in some areas in the echo, in this case, the patient pass to anticoagulation. This is normally the protocol.
Okay, thank you so much. The last question for Dr. Amal about the mechanical circulatory support. The question is about the when you put the LVAD in the patient with advanced heart failure. Do you think there's any chance to remove it, or this is final decision to go for transplant? And also some people, they talk about that it is sometime in some patients, especially adult, it might be the final stage and it would be similar to the transplantation.
Yes. When you go back to the data that we have of the patients who already went for VAD, very small proportion of those who go for VAD. It's about 5% only. And the only explanation for this, so you have to examine your patient in details. You have to know what is the pathology. If it's a dilated cardiomyopathy, is there any possibility of improvement or recovery? The main explanation for those patients who can be removed, can be off VAD, is the reverse remodeling by unloading, chronic unloading of the left ventricle. That I can explain that those patients might recover, and it is really less than 5%. So that's why it's recommended, if you are not sure of the diagnosis of the new patient and is not doing well, to go for temporary support. And it can help you or to do further investigations and checking of his trajectory. Is he improving or not? If you require durable support or not. And yes, it happened. In my experience, I saw one patient who was decannulated, although it was a positive gene. It was the patient was very sick when she came, with the unloading of the ventricle. Within 8 months, she was off VAD, but she was on heart failure medications, and she did not require VAD. And I went through many cases in the adult population. Therefore, for kids, let's say for kids, we list all the patients for transplant, and we keep the patient on VAD. We assess the ventricle, left ventricle, after chronic unloading. If there is a recovery of the LV ejection fraction more than 45, you have to check also another measures by echo and by cath. If you are happy, you can remove the device and see, which is very rarely happen. And destination therapy, no, not for kids. It is bridge for transplant. For adults, yes, they usually put the VAD, and they don't list the patient before 2 or 3 years, then they will consider transplant if the patient is not recovering.
Thank you so much, Dr. Amal. Finally, I would like to apologize to Dr. Muhammad for the last presentation because we are running short of time. Inshallah, we will reschedule it again in the next webinar. There is so many questions about the fellowship, but I cannot answer all these questions. Please, if you could put it on the WhatsApp group, because I think most of the people joining this WhatsApp group, and then we'll answer you in details. Finally, I would like to thank all the speakers, my colleagues, for their excellent lectures. I would like to thank you, the attendees, for your presence, and I think we achieve, mashallah, very good number, like at the beginning until near the end, like 560 attendees. So thank you so much for everyone, and then see you inshallah in the next webinar. If Prof. Amr want to end the talk, please.
Thank you so much, Dr. Osama, Dr. Demna, Dr. Amal, for this very nice presentation. Again, we apologize for Dr. Muhammad because we ran out of time. Receive a certificate of attendance by next week, and all should get also the recording of this webinar by tomorrow. And for all your question about our fellowship, will be in touch. I already shared with you right now our WhatsApp group. If you haven't joined our pediatric cardiology WhatsApp group for free educational activities, please do. We are going also to email you and contact you on your WhatsApp. If you have any question, feel free to reach out, and have a good rest of your day, your afternoon, your evening. Bye.
Thank
Bye
you.
bye.
Thank
Thank
you,
you.
everybody. Goodbye. See you, inshallah. Assalamu alaikum.
Assalam.